skeletal and neurologic causes of some of these pleuritic cardiac, chest but non-cardiac pain causes, as well as some of the associated Chapman and visceral somatics, talking about the history and the principles of FPR and still technique. It's not as common now, but sometimes those also do appear on boards. So we're talking about the names of some of these things that'll be important to know, some of these peoples that I'm going to mention, as well as the indications and contraindications for doing these techniques. All right, so without further ado, it's time to talk about ribs. All right. So again, briefly going through these. If anyone has any questions, let me know. Showing you the overall structure of the thoracic cage here again. Some of those anatomic landmarks, very useful, especially in lab today, to make sure you note these, to be able to find out which ribs you're going to be talking about when you're trying to do diagnoses. Spine of the scapula, for example, is going to be 3, T3 and rib 3, and then going to the inferior angle of the scapula should be that T8 or rib 8, sometimes T9 as well in that region. In the front, you have your sternum manubrium for rib 1 and 2, all right? And that T4 is going to be about that rib 2, that sternal angle as well, okay? So now we talked about sternum and thoracic cage a little bit. Time to talk about the rib cage. Rib cage, all right? So you all should be familiar with this picture here. Should know these concepts. Briefly going to go through them again. So costal cartilages throughout these ribs is going to be what's going to allow a lot of these torsional, rotational movements of the ribs throughout the inhalation, exhalation phases, as well as when you're doing your side bending and movements throughout your day. That cartilaginous structure will allow a lot of these movements to occur, okay? So who can tell me what the atypical ribs are?
1, 2, 10 through 12.
All right, perfect. Excellent. So we've got those atypical ribs here, and that's going to be for various reasons, as I'm sure you all know. Again, if there's any questions on that, please let me know. Yes, exactly. Anything with a 1 or a 2 in it is a great way to remember that. Okay. Okay. So next is talk about these typical ribs. Who can tell me what the typical ribs then by association would be? What numbers are our typical ribs? Excellent. 3 through 9, exactly. And that's what's going to make a rib typical is going to be these findings here. It's going to have those articulations with both the superior thoracic vertebra as well as the associated corresponding vertebra. It's going to attach twice at the head, and then it's going to also attach at the tubercle as well. It's going to have that shaft, and it's going to have that neck, okay? So those are all going to be associated with a typical rib. All right, so now we have this picture here showing our 6th rib. So again, you can see here where it's going to be attaching at these 3 facets for the rib superior, for the vertebra superior to it, as well as its corresponding vertebra at the actual body, and as well as that transverse process, okay? So here's that rib coming in here. All right. So who can tell me the name of these 2 most anterior facets? What would you call these facets? It's going to have to do with the structures that are attaching here. So you got a rib. Perfect. Yes, exactly. Costovertebral. Costo rib, vertebra, vertebral body, right? So these things are pretty easy to name, okay? Good. All right. So what about this one here? This one on the back. It's going to attach the rib to the transverse. Perfect. Yep. Transverse process. Exactly. Costotransverse. Excellent. Okay. And then if this is the 6th rib, what vertebra would be here and what vertebra would be here? So what vertebra is above it? What vertebra would be directly across from it? Excellent. 5 above and 6 below. Perfect. Again, so we'll talk about this a little bit later. I want to make sure this picture was clear to everyone. So again, when you're having these thoracic vertebra dysfunctions, for example, you can have an issue with the rib that's attached from the one above and the one directly corresponding to it. Or if you have rib dysfunction, vice versa, can have some of those thoracic dysfunctions. Usually going to be the thoracic that's going to precede the rib dysfunctions though, right? It's more common. Okay, so who can tell me what the true ribs are? The ones that'll attach directly to the sternum. Excellent. Perfect. 1 to 7. How about our false ones? These are the ones that have a cartilaginous attachment but aren't exactly attached directly themselves. Perfect. That's that 8 through 10. Great. And then our final ribs, by association, you all know this then. 11 and 12 are floating ribs. No anterior attachment at all, only attached to that posterior aspect. Perfect. Okay. So we've got the muscles here, just kind of quickly showing the primary muscle of respiration, that diaphragm, giant muscle that goes all the way across the abdomen, massive amount of connections going to all the way to the lower ribs, all the way down to the lumbar, up to the xiphoid, from that anterior sternum attachment up here, all the way down to that lower lumbar, okay? When you're talking about the actual crura, so we're attaching the lumbar, just noting that that right crura is gonna go a little bit lower than the left crura, so the left crura will go about L1, L2, that right crura, which is basically the attachment shown here, is going to go a little lower to about L3 or 4, okay? And then talking about some of these muscles of accessory respiration. Again, you have your external intercostal muscles, which will help with more inhalation, and then your internal intercostals, more exhalation. There are other muscles as well associated with that, which can be shown here. Rectus abdominis, for example, for that expiration, force expiration specifically. And the serratus also has play, pec minor, sternocleidomastoid, all of those. If you see people using any of these accessory muscles, usually a sign of respiratory distress, okay? So a lot of times in the hospital, especially ICU, you see patients doing that. You're thinking, okay, are they having any kind of respiratory distress? Are they having any kind of anaphylactic episode? Are they having any kind of, atelectasis, for example, or are there such respiratory compromises? So you wanna make sure you're checking the pH balances, checking their airways, making sure they're doing okay. Really obvious in kids, yeah, exactly. Yeah, you really can see that increased respiratory exertion in the kids because it's so superficial with those muscles. Perfect. All right, so there's rib motions here. So pump handle, what are our pump handle ribs? What are the pump handle ribs? These guys. Pump handle, you're pumping up and down. I'm sorry?
1 to 5.
1 to 5. All right. Again, that's going to be the board answer. That's going to be our test answer. In actual clinical practice and physiologically, they do have combinations of motions. So these are not always hard and fast, only this motion, but important to know, 1 to 5, mostly going to be that pump handle. And then for our buckets, what are those going to be?
6 to 10.
6 to 10, all right? So got that lateral, inhale, exhale, inhale, exhale. Perfect. Bucket handle motion, 6 through 10. Excellent. Last one's caliper by association must be 11 and 12. All right. That's going to be that motion here. Inhaled, exhale. Inhale, exhale. Okay. Caliper motion. All right. Great job, everyone. Again, showing here the fact that they are actually a little bit combined with the real motions that you'll note palpably when you're doing your exams today. Again, 1 to 5 pump, 6 to 10 bucket, and 11 to 12 caliper, but that rib 1 mostly is going to be an elevated and depressed superior inferior kind of motion. So it actually kind of more so resembles that kind of bucket motion, but again, we're just elevated depressed. It's going to be classified as a pump handle motion here because it does have that combination. When you're talking about 2 through 10, they do both, but your majority talking about pump handle 2 to 5 is going to be upper, and the lower 5 are going to be that pump handle, and 11 to 12 are a little bit different with their caliper type motion. So that kind of that lateral deviation with that motion. Okay. So just a quick review of some of these things here, right? So talking about the body as a unit, right? So, rib function is, again, heavily modified by vertebral positioning. So if you do have that thoracic position where you have that posterior left thoracic vertebra, for example, you would expect to have a left posterior rib on that same side, using the corresponding vertebra. So if you have a left thoracic T7, you're likely going to have a 7th rib posterior as well, or back, and you might also have 6. So we'll talk a little more about that later on, okay? Those are common things you're going to find. Then you'll likely also have dysfunction, inhalation, exhalation if you have that vertebral restriction as well. So again, for neutral somatic dysfunctions, scoliosis is going to be more of a group restriction. So you're going to have more ribs in a group that are going to be restricted. And if it's more of that type 2 flex extended, then it's likely going to be that single rib dysfunction associated with the corresponding rib, okay? That's because of the facet attachments of the vertebra as well as the actual muscle attachments from the long and short restrictors that are attaching through those segments as well, okay? So a lot of times checking for rib dysfunction means you also really need to check for that vertebral dysfunction. And big thing to note would be when you are treating a rib dysfunction, you're going to want to treat first the thoracic All right, so always treating centrally, then going peripherally. Treat that central thoracic vertebra first, and then go for that rib if it isn't already treated, because oftentimes you treat a thoracic segment that's associated with that rib, and the rib dysfunction will also resolve. Okay, so that'll save you time and efficacy as far as clinical applications. Okay, so we have our group inhalation. What would the key rib be for an inhalation somatic dysfunction?
Bottom.
The bottom. All right. So here's this kind of showing a little bit. So you have that inhalation, the ribs are stuck up. So then the one you need to treat is that one that's holding the ribs up, which is the bottommost rib. Treat that rib. The other ribs can fall back down into their normal position of ease. All right. So that's what you're talking about. It's going to be elevated. You're going to treat that bottom rib to lower the other ones back down. Easily goes exactly that bite mnemonic. Bottom inhalation, top exhalation. All right. So when you're talking about these ribs, they're going to like breathing in, they're going to come up nice and easy. You try to exhale, they're going to get stuck. So they're going to have restriction in exhalation, but they're going to easily go in inhalation. So inhalation somatic dysfunction. And the exact opposite here, it's going to be, oh, yep, that's right. I couldn't figure out how to make this one go quicker. But yep, so we're going to have that group exhalation, means treating that topmost rib. The top rib is holding everything down. So you treat that top rib and then everything else can come back up into normal inhalation. Exhale, perfectly fine. Exhalation dysfunction. Inhale, you're restricted, right? Perfect. Okay. So this might be a newer concept, so I want to make sure it's clear to everyone that you can have anterior and posterior ribs. Should make sense from a standpoint of anatomy, right? So you have a rib in space. It can be a little more forward or a little more posterior, as well as it can also be superior or inferior. It can also have that torsion because of the cartilaginous attachments. Oh, sorry. Yes, so when you're talking about an anterior rib, usually there's going to be more so diagnosed when you're having a static diagnosis. So you're running your hands over the rib cage, doing that examination in the front and the back. You notice one rib is a little more forward than the other. It's more prominent. Okay, that's going to be an anterior rib. And you'd note that by checking inhalation and exhalation, you're likely going to have either no restriction or equal restriction in inhalation and exhalation with these ribs. So it's not a distinct group dysfunction. It's that one rib that's just anterior or posterior, okay? Usually gonna have some tenderness over that area as well, all right? So the anterior rib is gonna be more prominent. Something happened here. Okay, so something happened when I translated this over. I'll have to modify the slide, but anterior rib will be less prominent. Don't know why that happened. Less prominent, okay, in that posterior aspect and more prominent in the anterior aspect. So this wording is actually going to correspond with the posterior rib. I will change that and have that updated. It'll be correct in the lab today. But so I'll talk through it. On this side, this is going to be correct. Okay, so the anterior rib, you're going to have that rib angle being more or less prominent in the back because it's going to be forward. You can still have some tenderness over these muscles, but likely more so in the anterior aspect of the chest. So over the pec minor, for example, if it's one of those upper ribs. The anterior rib will be more prominent at that sternal attachment. Laterality will still be the same, okay? And then you're going to have that restriction with inhalation and exhalation. Again, sorry about that. Not sure why that happened. Some nomenclature for how to name these ribs. All right, so you're going to have the single or you can have a group dysfunction. So for an example, you can have the left rib 2 or the right rib 3 to 5, for example, in terms of single or group dysfunctions. You could name one by that, again, that elevated or depressed because of that ribs usually moving that caudad and cephalad motion. Then you're going to have a static rib, just one rib could be anterior or posterior. It could also be a group and have that inhalation exhalation dysfunction, okay? So making sure you all know how to name these, very important. You don't have to state, just a quick note, that pump versus the bucket, but it's going to be important to know. So when you're actually checking, you know what part of the rib to be checking. So pump handle, you don't really want to be on the side so much. You want to be more on the front, the back, so you're really getting that motion. Bucket handle, more on that transverse aspect diameter, so you can really see that excursion of the ribs take place, okay? All right, so here's that summary table here. Great table to use to make sure you all really are getting this, okay? As far as, again, testing, we'll make it clear for our test boards. We'll usually use these, especially for muscle energy, anterior, middle, posterior, the pec minor for 3 to 5. The serratus anterior is usually going to be the muscle they'll mention on boards for 6 through 10. So if you see these other muscles for 9 and 10, you could choose them. But because the literature is a little off, we don't have a synonymous take on what we're going to say. Usually we're going to have serratus anterior being 6 through 10, but if you see serratus posterior, you will not see serratus anterior, you will not see the latissimus dorsi. So knowing these will be important, both anatomically as well as for your treatments, but noting these are the muscles you're going to find. And then again, same thing for 11 and 12. It could technically be either of these, even though the attachments to the muscles don't exactly correlate with these. We're not exactly clear on these from book to book, but either one of these could be associated with those caliper rib motions. So making sure you know lat dorsi and QL, okay? Again, just quickly talking about each rib is going to have that innervation. Going through each individual rib, you're going to have these veins, arteries, and nerves running on the internal aspect of the rib, okay? And showing further, this is why it's going to be so useful when you're doing the rib raising, for example, because you're able to virtually directly contact this sympathetic chain ganglion by using those rib heads when that patient's going to be in that supine position, right? So very, very useful to do. You can also have rib compression, especially that first rib can compress the cervical plexus, talking about that thoracic outlet syndrome, the brachial plexus nerves running underneath, subclavian artery and vein running under there. Very important to be able to clear up the first rib dysfunctions for any patients that are presenting with that numbness, tingling right down the arm, pain right down the arm. Those can all be caused by this kind of thing. Thoracic outlet syndrome is pretty serious. Seen in the hospital, these treatments can really help a lot of those patients if it's caused especially by a rib dysfunction, okay? So quick review, which ribs are going to be atypical? Ones and twos. Perfect. All right. So talking about pleurisy here for pleuritic chest pain. So that pleuritic chest pain is basically going to be that sudden, usually intense and sharp stabbing, burning pain in the chest. More common with inhalation, but can also be present with exhalation as well. This is very commonly seen with patients that have what diagnosis would you most commonly see a patient with pleurisy? Can be common in pericarditis. Good, good. Yes, costochondritis. That inflammation of the anterior aspect of the ribs. Definitely. PE can have it as well. Good, good. Pleuritis, okay. Yeah, pleuritis would count, but it's kind of technically the definition of it. So again, that pleurisy, pleuritis, we're talking about the pleura around the lungs. So you have those two different layers of membranes that are surrounding your lungs. You're going to have that parietal and that visceral. So you're going to have the parietal being the outer and the visceral being the one that's really hugging the lung. When those rub against each other, that's causing that pleuritic chest pain. So yeah, trauma, pneumonia can cause this, PE, costochondritis. At big time with pneumonia, you're usually going to see this pleurisy taking place. All right. But great answers. Perfect. So that approach when you're having this patient come in with this chest pain that is non-cardiac, right? You don't always know it's cardiac when they first present. So you want to make sure you're doing your full exam, depending on what the patient can tolerate, checking their posture, checking their spine, their ribs, checking those associated viscerosomatics, sympathetically and parasympathetically, and then checking their diaphragms as well. Even before you're treated, you can do this very quickly, just examining these areas. And then if you find dysfunction, that can kind of clue you in, all right? So your goals are going to be listed here a little bit. So again, addressing things that are asynchronous with motion or restrictions and tissue texture changes you're noting, and any pain the patient's presenting with. Usually, again, pleurisy, pleuritic chest pain. It's maybe the anterior aspect, usually more sternal, but could be to the left or right, depending on the actual diagnosis here we're talking about. So being able to take care of any segmental facilitations, decreasing usually more sympathetic input is going to be useful here. Also talking about the other aspects from the organ, targeting all those areas, targeting the circulatory and lymphatic regions as well, okay? So here's a general, not all of them, but the most common things you're gonna see with that chest rib pain differential, okay? So you have the MI, one of the biggest ones you're gonna wanna rule out, followed up closely by, that pulmonary infarct, right? That aortic dissection, these are all really big things you do not wanna miss. So again, When you're talking about more of an outpatient, it's actually found that about 36% outpatient-wise is going to be MSK causes, so more of your chest pain from that costochondritis, TT syndrome, musculoskeletal injury, trauma, inflammation, those kind of things. Could be GERD, could be stable C, coronary artery disease, or even panic disorders in patients. Especially, people in more stressful environments, medical school, for example, people can get these panic attacks from high anxiety, and making sure you are able to roll that out. You're reading about heart attack and you're thinking, oh no, I'm having some chest pain. Is that a heart attack? Much less likely. You want to ease up, go to the doctor, get evaluated. But panic attacks, simple musculoskeletal issues, rib dysfunctions, all can commonly cause these things as well. Just so you all know, in the ED, though, you're much more likely, especially when you're on your ED rotations, for example, or inpatient rotations, seeing more serious things, these MIs, these pericarditis. But 54% of those people that are going to present to the hospital will actually have something more severe, like an MI, for example. But in the outpatient, usually more musculoskeletal and less ischemic. Okay. So important to know that. One of the things not on here necessarily specifically, but virus is also very common. So, you have the Coxsackie, the RSV, influenza, mumps, EBV, all these things can also cause some of that pleuritic chest pain as well, okay? So what can we kind of do when we're addressing these with OMT? What are some of the techniques you might want to do, or regions to treat, for example? You can spit them out, you can write them down, whatever you want to do. Good, some MFR. Any particular regions you might want to go? Regions? I've covered a lot of techniques over the first and second year here. Yeah, anterior sternum, very common spot, very common to have some of that costochondritis pain over that anterior sternum. Anyone else know anything you might want to do for someone having some of that pleuritic chest pain with some of these diagnoses here? Sympathetic chain, definitely. If the patient can tolerate it, yeah, you can do some muscle energy, exactly. Definitely getting that OA, being able to target some of those parasympathetics, bring up any restrictions. Yeah, rib raising, great, perfect. All right. Yes, if indicated and not something directly over, you can do a thoracic pump. Usually not your first line, but definitely something to do later on lymphatically. It can be a big help. Good point. Perfect. All right, so again, here are some things you could use. You can go through your seated position and evaluating these areas. You can do supine, evaluate these areas. If you have a couple minutes, running through some of these real quick, covering those ribs, covering the diaphragm, getting in that suboccipital. You got a few more minutes clinically. You can cover more things like the inlet, sternum, thoracic, going over the diaphragm again, getting the suboccipital. And these just keep growing. If you have a long time, a full visit, for example, that full 15, 20 minutes, you can go through a lot more areas, covering everything from the head all the way down through thoracic and lumbar, really clearing out, making sure you're targeting viscerosomatics, those Chapmans, getting to the lymphatics, making sure there's no fluid congestion, especially in the lymphatic system, very common in people that have an infection that can't clear out their lymphatic system. So it actually causes more serious implications and severities than they would otherwise have. You can also do, I don't know if I have it on here. I do. Okay, yeah, trigeminal nerve release, for example. So trigeminal nerve is going to have that sensory input going to the upper respiratory tract. So being able to target those, doing some palpatory releases, direct inhibition type motions will really be able to, direct palpation over those areas, doing oscillatory type motions can really help patients by freeing up both their sympathetics, parasympathetics that are running through there, as well as opening up some of those channels as well from nasal congestion standpoint and secretions, okay? They've actually done studies on that prove that can be very useful, all right? So again, real quick summary slide. I'm sure you all know this by heart by now. Showing some of those Chapman's points here. This should be review. All right, so you got the anterior, you're gonna use these to diagnose. Patient comes in, you're saying, oh, okay, let's do that structural exam. What do we have going on in that, that sternal border here? Okay, we got some of these Chapman's points, some of these little beady tissues. What could we be thinking as a differential? Can kind of narrow you down if you have some of these lower lung Chapman's points and not these upper ones, talking about the heart versus the lungs. You can kind of key yourself into potential diagnoses without even ever having to order a lab, right? Really can help you in the acute setting. If you don't only have a couple minutes and you're trying to decide, what do I need to get this patient? What do I have to do? I don't have time to wait for an x-ray to come back or a lab. in the acute setting, having some of these things can really help to key in and verify your diagnosis, all right? Or bring down your differential at the very least. More so for treatments going to the posterior aspect of these Chapman's points, okay? Showing them here. Then you're gonna have these visceral somatics. I'm sure you all know this by now. So you got that T1 to 5 for the heart, and then 1 to 6 for the lungs. Could vary a little bit, but that's gonna cover all the points that it would be. Maybe 2 to 6, but still 1 to 6 will cover you for our test and for boards. Knowing for the vagus, you can target it because of the way it's gonna run down that cervical spine out of the head and into the abdominal cavity, covering the occiput, covering C1, C2. It's going to run right lateral to those. You can treat these areas to target that vagus nerve pretty directly. Okay. Again, just showing that again here, a little sample treatment you could do. So doing some of these visceral somatics, pairing that either by doing it with paraspinals, rib raising, however you're going to want to target those, getting more OA for the parasympathetics, the suboccipital release, especially releasing some of the musculature surrounding the OA region in the top of the cervical and the lower capitis, doing some lymphatic and vascular type techniques for that thoracic inlet and abdominal diaphragm. Again, some rib raising can be useful here too. Before any lymphatic, of course, doing the inlet and then covering your Chapman's points as well. If you have time, throwing in some of those pumps can really help as well. Good. Okay. I don't think it's on here. No. So another good point is to also cover phrenic nerve, especially if you have diaphragmatic irritation. Very, very common with a lot of these respiratory issues. So you're going to have that decreased excursion and overuse and irritation of that diaphragm. Treating these areas, C3 to 5 can really clear up and get more mobility and motion of that diaphragm, helping increase your lymphatic fluid motion a lot better. Okay. Okay. Pivoting a little bit here. So now we're going to get into our topics for our lab, briefly discussing these. So you have direct versus indirect. I'm sure you all know those pretty well by now, but now we're going to talk about combined technique. All right. So this is when you're putting them all together. So reasons you might want to do this is one, if you are a little more comfortable with your direct and indirect, you feel you know the ways and ins and outs of doing these techniques, you can put them together. It can save you time. You're going to get that quick adjustment. You're able to go directly into the barrier, but in a lighter degree of force and not as traumatic or intense for the patient. So if they can't tolerate a full HVLA, for example, muscle energy, being able to do these other combined techniques can still get you through that barrier directly and quickly without having so much force needed. All right. Just showing that again here. Direct, indirect, versus combined. First technique we're talking about here is going to be a little more on the indirect side. That's going to be our FPR. All right, you got this lovely man here. His name is Dr. Stanley Shiowitz, and he is the creator of facilitated, piston release. All right. So brief description here. This name may or may not come up in the future for our tests or for boards. Important to know. This guy did a lot for our profession. This is a technique that he utilized to have quick, effective treatment methods from an indirect standpoint, tolerated by many patients. We're talking mostly patient passive, not doing anything themselves, indirect technique, similar to some other techniques you should know, talking about counter strain. Yeah, so yeah, another one that's very similar to this. He practiced it a little differently, again, that combined method. So when you're doing this technique, I'll talk about it a little later, you can do the indirect. And then at the end of that treatment, just going into that barrier a little further. That's something you can work on doing once you get a little better at doing the initial setup of these treatments. Initially focusing on the indirect side is perfectly fine, okay? So that FPR, so again, this is what we're doing here. We're talking about a treatment method that can work virtually in any part of the body, really starting off in that neutral positioning, taking out for the spine, the AP curve, or if you're working in an extremity, decreasing the joints, compressing restrictions, making that joint loose and lax, freeing up any restrictions over the joint you're working on or the muscles you're working on. Then adding that compressive activating force or torsional or traction. It doesn't matter which one you use. Usually more compression is going to work better for certain muscles because you can approximate better with the origin insertion, but any of these motions will work, okay? Again, it's an indirect myofascial style treatment, okay? All right. Very similar to counter strain as well. So quick question here. Oh no. Okay, perfect. Okay, good. All right. So which of the following would rib 7 be classified as? 1, 2, 3, or 4? Okay, just throw up your fingers. Who says 5? All right. Good job. Perfect. So indications here, pretty similar to most of our techniques. You're talking myofascial, you're talking articular, muscle, fascia, joints, right? Contraindications, similar to the ones we're talking about for a lot of these as well. So you have a fracture in the area, you're going to make it worse, don't do it. You have neurological symptoms that are coming. My arm is going completely numb, I can't feel it. I'm getting intense paresthesias, numbness, and tingling. You stop right there with your treatment, okay? Anything that's going to exacerbate life-threatening symptoms, right? So if you're putting the patient in too much extension, for example, and they have some of that vertebral artery issue, if they have significant EKG changes, if you start having a lot of palpations or other symptoms, you want to take that as an absolute contraindication. Lack of consent always, and then some of our relatives, again, pretty similar to most of the techniques we're talking about, but if it's not well tolerated, if they have a little bit of increased pain when you're doing this technique, not necessarily a reason to stop. If it's minor enough and the patient's okay with you continuing, but again, checking in with the patient to make sure they're okay is going to be important, right? And of course, you have that joint instability, some arthritis, for example, or some minor impingement, but that's not getting severely compromised by doing the technique, are all relative, okay? Important considerations here. So again, pretty easy to apply and very efficient, very quick, generally technique to do. So these are some of the quick, just special considerations to kind of keep in mind here. Again, you need to have that activating force, whether it's compression, torsion, or traction, or okay. Usually going to target that superficial tissue first and then go more deep thereafter. You're going to always start with that neutral positioning, take off that excess restriction and cause that release, that ease, that idling, unloading of the joint you're working on before you're going to do the actual technique, okay? So that's going to be, again, that unloading of that joint space for the spine or the extremity, okay? And here talking 5, again, adding that direct component if you want, as Dr. Shiewitz did. You don't have to do that. That's just an option. Once you get better at it, if you notice there's still some restriction, you can add that too. All the techniques we do in osteopathy, you'll learn later on, they can be combined when you're actually clinically working on patients. So you already know, I'm sure, all about the gamma motor neurons. I'm not going to talk about this here, just a quick review. But here you might not know. So again, the proposed mechanisms for FPR specifically, what we're doing is decreasing that gamma motor gain on the spindle, quieting down that gain, reducing the stimuli that's causing that increased stretch sensitivity, so that with the decreased stretch sensitivity, you're able to kind of work with that muscle more freely. It's got allowed to get more motion without having to have that massive amount of contraction because of the increased sensitivity to that stretch. All right, so by able to disengage this joint space and bring it to a neutral where it's in that idling position, you actually can inverse that spindle output. Okay, that's how we're going to be doing this. You're able to let that muscle fiber reset, calm down. It's going to decrease the affin input. It's going to reduce the alpha motor neuron stimulation, reset that feedback loop, and allow for muscle relaxation. All right, so ribs 6 to 9 on the right are found to be exhaled. Which rib is considered the key rib to treat? I got an answer. All right, confirming answer, perfect. Excellent, rib 6, perfect. Okay, so our principles of diagnosis here. So we're gonna have our structural diagnosis methods. You're going to check for that muscle hypertonicity or that articular dysfunction. You could have both, you could have one or the other. Going through all the planes, and then you're going to have your diagnosis based on all planes. Again, starting off first by having that neutral position, unloading that tissue before starting your treatment. That's going to help decrease the nociceptive inputs and the proprioceptive increased afferent stimulation from stretch reflex as well. Once you're there, you can do your full process. So you're going to, of course, monitor the entire time. You're going to flatten that AP curve for the spine if you're working in a specific spinal region. So cervical, you're going to have more of that lordosis. So you're going to want to decrease the lordosis, kyphosis in the thoracic, and so on. Lordosis lumbar and the sacrum, more of that kyphosis as well. Okay. So once you have that done, you can add your force, compression, torsion, traction, or multiple. Again, you can start off with just one. If you notice, okay, I get some release if I'm doing that compression, let me try adding a little bit of traction and seeing which one of those is going to better have response tissue texture change-wise in your patient, okay? Once you're there and you have that force applied, after being in that neutral, then you're going to take to the ease, just like counter strain. It's virtually the same position as counter strain you're taking them into, just first flattening out that curve and adding in this force vector. Then you're going to take them into that ease position. You're going to hold there instead of 90 seconds, just 3 to 5 here, okay? Then you can return back to your starting position and reevaluate. All right, just showing those spinal curvatures here that you're going to have to straighten out. You can use pillows, for example, to straighten it out. You can use, the practitioner can do it themselves. Raising the bed, for example, all work for straightening out that curve. And we'll talk about that this afternoon. All right, so that treatment goal is going to be here, affecting those large or small localized muscle groups. Quick ways to differentiate between FPR and counter strain. So again, you have FPR. Big thing is going to be that neutral unloading that's going to initially take place, okay, versus counter strain, where it's more so just going straight into that indirect ease position. You're going to unload first with FPR, then go into that ease position after you've applied that compressive torsion or tractional force. Much quicker technique, right? So notice it's a lot faster, 3 to 5 versus 90 seconds. More input from the practitioner is going to allow that quicker response to take place using more reflexive changes, okay? Still indirect, still passive. So you got FPR here on the indirect side for the most part, might cross over a little bit depending on the practitioner. For the most part, it's going to hang out here, all right? Still technique though, right on that line. So we're talking about still technique next, and that's going to be both. By this wonderful doctor here, Dr. Van Buskirk, is not the actual creator of still technique, but he's the reason why we know about it today. So Dr. A.T. Still was the one who did this technique fairly regularly, and along with his other joint treatments, usually being more direct in his treatment style. This is one that's a combination technique that he did, that he was noted to have been seen doing by his early followers. And Dr. Van Buskirk, for example, was one of the ones who was able to really talk to a lot of these different practitioners, compile all this data, write a book on it, and bring this into the light. He got his FAAO for this, and it's a technique that is similar in nature to treating things articularly like HVLA, but is not as direct or forceful, so a lot more tolerated, okay? But this was not specifically written by Still. This is something that Dr. Van Buskirk really was able to bring to the forefront, all right? Just a quick quote here. Time's sake, I'm gonna have to move on through. All right, so when I'm talking about Still technique, again, this is something that is from the old doctor, as he's called, from A.T. Still, that we have brought forward to us. It's going to be a cross between different techniques and different style approaches from the direct to indirect, working again similar to HVLA, going into the barrier here as we're talking about, but also going to be softer, more fluid. Instead of having that articular, what do you call it, like the crack, for example, you're going to have a little bit of a clunk, might have a little bit of a pop, but you don't always have to have that really loud sound like in the HVLA you might normally have from the articulation. We're going to classify this one as a specific, non-repetitive articulatory method. Okay, it's indirect first, then it's direct. All right, so pretty similar with FPR as well, in the sense that you're still going into the ease, but with Still technique, you're going to actually go into the ease and then further exaggerate that ease, going further into the ease to further loosen up and cause more laxity at that segment, okay? Instead of the FPR is more easy neutral, basically meaning you're flattening that curve to a neutral position and then going to the ease. This you're gonna go to the ease and then exaggerate that ease further before going further into the other motion, which will be the barrier, which is gonna be the opposite of how you're gonna be working with FPR. So in this case, you're gonna go into that ease first, exaggerate it, and then move into that barrier to clear that restriction, okay? But we're gonna start off in that ease first. And this is going to work through, again, the same below here, repatterning. So you're working from a neurofascial and vascular component. All three of those are being targeted, but instead of going away from the ease into the restriction, causing increased stretch response, you're actually decreasing the stretch response and causing more of a neutral tone over the musculature or the joint space. Quick question here. I'm going to skip through this for time's sake real quick. What is primary motion of rubella rivette? Fucking handle. Good job. All right, perfect. So, steps for Still technique. All right, just want to note this one in your slides. This is a little bit different here. It's the same phrasing, just change the words a little bit by taking off, I think it was a the, and a van, and an and or something, just to make it a little clearer. All right, so feel free to write that down. Yes, I believed in you all. I knew you all knew that answer. Perfect. All right, so just talking about these steps here. So you're going to have the patient being passive the entire time. This, just like the FPR, is going to be the practitioner doing the technique. You're going to diagnose that joint in all three of those triplanar positions, finding the ease in all three. You're going to take the joint or muscle into the ease, then exaggerate it a little bit further. Then from there, you're going to apply a force similar to the force we're talking about with FPR. It could be compression, it could be traction, all right? But it's going to be about 5 pounds or less amount of force directly localized. So depending on where you are, you need less force versus more force depending on how long your vector is going to be. So if I'm working in the cervical and I'm pointing the head as my lever, all right, then I only need to apply a little bit of force versus if I'm working for the shoulder, working all the way, you can't see it. But down to my lumbar, for example, then you need a lot more force, right? But that's a general rule of thumb, okay? Holding that force down is going to further disengage that joint space, cause more laxity there, more unloading of that area, and allow you to then push into the barrier. All right, so you start in that ease, exaggerate the ease. You're going to have that force applied, compression or traction, and then you're going to move while holding that compression or traction vector force into the restriction. Okay, it's a very quick process. We're going to have a little video to show what that actually looks like, as well as in lab. I will demonstrate this to you all. Okay, once you're through that restriction completely, you can release your force. You might have that pop or click, you might not. Then once you're done, you return to neutral and reassess. Here's going to be that quick basic step slide. Again, some minor changes here. A few seconds, perfect. Okay, again, nothing big, just a little bit of word cutting to make it a little easier to understand. Big point on this slide is making sure you know that force vector is going to be very important for doing the still technique. You need to make sure you apply that when you're doing this treatment. And maintaining it actually is the biggest thing. Applying it, maintaining it throughout the entire process of going from the ease through that restriction completely. Then you can release it back to the neutral and recheck, okay? So we're talking about knowing your anatomy, always having the correct diagnosis, always. Pivotal, you don't know it, can't really do a correct treatment. Indications, again, are pretty similar, very similar articular dysfunction, myofascial dysfunction. And then we're going to have our absolutes versus our relatives. These are the same absolute contraindications, a little bit different of our relative, but again, virtually pretty similar. So that arthritis, that spondylosis, that joint instability, strains and sprains in the area from muscular ligamentous injuries that might be mild to moderate, but not necessarily full tears. So you still have the ability to work on this segment because again, still technique is not too aggressive. Usually pretty well tolerated, okay? For your references, here is the high yield slide. Again, you are welcome. I don't think this is in your handout, so feel free to take a moment on that. Any questions here? We have reached the end of our didactic lecture. Yeah, that was a lot.
I had a
Tuning
quick
techniques.
question, Dr. Hamyang.
Yes, please.
For I remember for HVLA, one of the contraindications was patients who have trisomy 21. Is that a contraindication for still technique?
Not a direct one. HVLA again is more aggressive, more direct, so it has a lot more contraindications than any other technique. So that would not be a direct contraindication, but it would be something you'd want to have on a case-by-case basis. If again, if that patient can't tolerate that, if you're noticing too much laxity, you do want to hold off on doing these techniques, but not always. Correct. Good question.
Thank you.
Any other questions? All right, we're going to talk again about these in lab, but if there are questions, now is the time to ask because I'm going to go real quick in lab to make sure we have a little bit of that time to have that review afterwards. Okie dokie. All right, here are my references. So in your free time, you can read up on that. Thank you all very much.
Thank you. Thank you so much.